that you take in an inspiration and expiration. So a normal breathing, right? So, and at the same time, that is also called tidal volume, okay? So the amount of air or oxygenation that you take in a normal breath, and the normal breath entails inspiration and expiration, okay? So you either have a failure to ventilate or you have a failure to oxygenate. And you might say, well, it's the same thing. It's not. Because you might be breathing at 100% oxygenation in your alveoli on a room air, but you have a failure to ventilate if you have, for example, a flail chest after trauma. You might fail to ventilate because your mental status is unable to protect airway. Even if I do an ABG on you right now, and you have a GCS less than 8, it could be 98 or 100%. Do you understand? Okay? Same way, you might have a patient that it doesn't even seem on distress, and when you do an ABG on that patient, the oxygenation is less than 90%. Do you understand? So that's the reason why the concepts are completely separate. Okay? So, by definition, you are in respiratory failure if your partial alveolar oxygenation is less than 60, or your partial alveolar CO2 is more than 50. So you would say, that's the normal ABG on a patient that has COPD, and it's true. And even though, again, we see them all the time, walking in with even worse CO2 and even less PaO2, you're not going to intubate those patients or put the patients on BiPAP, right? Because you're walking normally to the supermarket without having shortness of breath. But by guideline, if the patient has a PaO2 less than 60 and a PaCO2 of more than 50, you must intubate. Do you understand? Okay. All right. Now, in addition to that, you will see next semester, that I can't go in details now, that you might also have a respiratory failure based on the arrangement of acid-base balance. Because if you now have CKD and you go in metabolic acidosis, or you have DKA and you go in metabolic acidosis, or you have an toxidrome that we'll study next semester, and you go in severe metabolic acidosis, you might also fail to either ventilate or oxygenate. Do you understand? Now, the types of respiratory failure. The most common two types is you're either hypoxemic respiratory failure or you're hypercapnic respiratory failure. Some will interchange hypercapnic with hypercarbic, same thing, okay? So what would be hypoxemic respiratory failure? A patient that has the normal CO2, right? 35 to 45, but the oxygenation, PaO2, is less than 60, right? And a hypercapnic respiratory failure, you might see a normal PaO2 90 to 100, but the CO2 is the one that climbs over 50. All right? Then you have a mixture, because you would see that some patients have both hypercapnic, hypoxemic respiratory failure. And I can show you some examples in real life. Okay? Now, there's other two types, and you can also see that some practitioners don't even write hypoxemic or hypercapnic. They write type 1 respiratory failure, type 2 respiratory failure, and you need to know what that means. Okay? So type 1 is hypoxemic, type 2 is hypercapnic. Some refer to type 3 and type 4. Type 3 is basically a perioperative respiratory failure, which if you think about it, could be from hypercapnic because it's hypoventilation after anesthesia. Or, in another hand, so that's more commonly, but on the other hand, could be hypoxemic just because they go into atelectasis, but still due to hypoventilation. Okay, we're gonna go there in a second. Type 4 is basically due to hypoperfusion. Most likely, again, hypoxemic, because if you think about the aerobic and anaerobic cascade, if you have a patient with myocardial infarction, what do you think is going to happen first? Hypoxia, and then you can retain CO2 if you get tired, right? So you would have hypoxemic more than hypoventilation. Okay? So type 1 hypoxemic, type 2 hypercapnic, type 3 is perioperative or postoperative, and type 4 is hypoperfusion. So think about all the disease process that can put the patient into ischemia and hypoxia, and that can lead to respiratory failure as well. So it's basically an overlap. You're not going to find that as common in hospital documentation. What you would find the most is type 1 and type 2. Okay? Why? Because they do overlap. Now, I just want you to listen to me and don't get confused with all these arrows and boxes, okay? So let's start with hypercapnic. If you remember in pathophysiology, what can produce the body to retain CO2? If you normally breathe oxygenation and you exhale CO2, you need to be breathing normally, right? At a normal rate to be able to exhale the CO2. So if at any point your breathing rate decreases, you're going to be unable to exhale CO2. And that happens, first of all, when you have alterations of mental status, most commonly, right? So if you have a patient with lethargy, obtundation, coma, think about all the disease process that can produce that, from stroke to opioid abuse, any type of narcotic that you give to your patients, Ativan, Haldol, yeah, any opioids, right? Any stroke. What else can produce that? Sleep apnea, hypoventilation syndrome. Let's talk about first what can make you breathe less. Okay? So any type of hypoventilation syndrome that basically is a patient that has an altered mental status. Seizures, for example, after seizures, that the patient mentation is compromised, right? Overdose, right? Think about the patient being sleepy, too sleepy, okay? So alveolar hyperventilation, that could be central. We're talking about central patients with CVA, after a seizure episode, opioid overdose, any, Ativan or Haldol, etc. Okay? And includes there as well obstructive sleep apnea syndrome. Now, but in addition to that, what about, because you don't breathe only through your lungs, right? You need, first of all, your pontine medulla to be able to breathe. So if you have a stroke there, you have a tumor compressing that area or affecting that area, that also can compromise ventilation.
That will be central, right?
That will be central. But what about the diaphragm? What about intercostal muscles? If you have a patient with a diaphragmatic paralysis after a CABG, or if you have a tumor in your lung that is paralyzing one diaphragm,
Or like myasthenia gravis.
or any disease process that can affect the muscles, Leal, myasthenia gravis, right? In addition to that, what else can affect the diaphragm? If you have a decreased AP diameter because you have a central obesity that's pushing the diaphragm up, you might take a good inspiration, but you get air trapping. And yes, of course, COPD. No, hiccups wouldn't allow you to retain CO2.
All those like that, diaphragma and all the stuff, that will be neuromuscular.
Correct. Or think about pregnancy, pushing the diaphragm up, so the expiration phase is more compromised, right? Or central obesity. In addition to that, you can have ventilation perfusion mismatch that can give you hypercapnia And let's talk in a little bit about overfeeding. That refers to carbohydrate accumulation. The carbohydrates decomposed on carbon monoxide and carbonic acid. So the accumulation or overfeeding with carbohydrates, so you have to select very carefully the feedings that you give a patient when a patient is a CO2 retainer, okay? Because if you overload them in carbohydrates like gelatin, 1.5 for example, that will be too much for them, they will retain more CO2, okay? The same as a normal patient that is eating, a COPD patient, for example, shouldn't take plenty of rice or sources of carbohydrates. They have to decrease it because they tend to accumulate carbonic acid and CO, more carbon monoxide. Okay, so if you remember, this is your capillary and this is your alveoli. Okay, I explained this in pathophysiology in the past, whoever was with me. Again, ventilation, the amount of air that is in and out in a normal breath, that is also translated as tidal volume. Perfusion is no more than the amount of oxygen that is transported by the hemoglobin at the level of the capillary, right? It allows interchange of oxygen and CO2 at the level of the alveolo-capillary membrane, right? Trying to take this to the lowest level so you can understand. So if you think about ventilation or the alveoli, when you talk about ventilation, think about lung. Think about lung and think about all the structures that support the lung, okay? And when I talk about perfusion, it's only the blood, the capillary, okay? Okay? So, what can affect ventilation?
No, sorry.
Think about the lung.
Inflammation.
First of all, you can have a completely normal lung, okay? Completely normal tissue parenchyma, and you still have ventilation compromised by all the diseases that we have gone through. What about your chest wall? What about if you have scoliosis, lordosis, kyphosis? What about if you have a chest trauma, you have multiple rib fractures? What about if you have a pectus cavatus or carinatus that can affect your ventilation, right? But going through diseases, any disease that you can imagine affects ventilation. And that is from asthma to cancer. So if I tell you pneumonia, ventilation. If I tell you pulmonary edema is ventilation. If I tell you lung cancer is ventilation. If I tell you TB is ventilation. Anything from a normal lung asthma to a pathological lung is ventilation being affected. Okay? But if the perfusion is not affected, the VQ mismatch is low. And that is called shunt. So when they say the patient shunting, you know that I don't have a PE. I have anything else but PE. I have an alveolitis, I have a atelectasis, I have a lung tumor, I have asthma, I have pneumonia, I have pulmonary edema, I have ARDS, I have anything else but clot. That is shunting, okay? So that means that ventilation is poor or affected, and perfusion is normal. And that is your VQ scan being reported as low probability. Okay? Then you have the backward effect. You have perfusion that is affected because something is blocking that capillary, not allowing that even though the oxygen reaches the wall of the capillary is unable to be transported by the hemoglobin. So you either have severe anemia, right? Or you have something that's blocking here. And that's a clot. That is PE, right? So when you have a normal ventilation, but a poor perfusion, the pathognomonic disease process that is present here is PE. And that is called dead space. Now, you might have the question that I have received in the past, is a dead space normal? Well, there are many definitions of dead space. Dead space in the pulmonary physiology means that the areas anatomically or artificially, and I'll explain that in a second, that gas exchange is not produced. The only structure in the lung that participates in gas exchange is the alveoli. So what about the bronchioles? What about the bronchi? What about the trachea? What about the pulmonary artery? What about the epiglottis? Right? What about the hypopharynx? What about the mouth? What about the tube? And the machine. So artificially or physiologically, structures that do not participate in gas exchange. Okay? So artificially will be your ET tube, your tubing, and the machine. And physiologically will be your hypopharynx, your larynx, your epiglottis, your trachea, your bronchi, bronchioles. Until it reaches the alveoli. That is the area that only gas exchange happens. But in a ventilation perfusion physiology, dead space refer when the perfusion, meaning the blood transporting that oxygen molecule, is compromised. Highly present in pulmonary embolic patients. Okay? And I told you about the overfeeding. This is repeated. So basically, now I'm telling you the disease processes. We already have gone through that, right? What about electrolyte imbalances?
Yeah, that's why we're getting
It's highly important. It's highly important that you replete your electrolytes if you want to extubate the patient. Because if you have hypomagnesemia, it's not only the matter of, okay, let's give potassium, let's give calcium, let's give magnesium. What would be the major side effect of hypomagnesemia? Muscle weakness. So if you have intercostal diaphragm escalating sternocleidomastoid weakness, doesn't matter if the chest x-ray is clear and if the ABG is perfect, that extubation will fail. Okay? I'm going to skip the case study. I'm going to talk to you about real patients. Okay? So let's analyze the ABGs. In case you forgot. Now, this is a simple way of analyzing ABG. Next semester is going to be real complex. You have to do calculations. You have to tell me if the patient has an acute respiratory alkalosis or chronic, if it has an acute respiratory acidosis or chronic, and so forth. Okay? It's going to be more intense for your own benefit.
What is it for the acute?
Next semester. Okay, so analyzing, if I tell you now, this is a patient with cabbage, I don't know how many years ago, COPD on oxygen dependent at home, and CPAP, that means that the patient has obstructive sleep apnea. So far, what type of respiratory failure are you expecting? Failure of ventilation. So that means that the patients most commonly will come to you with hypercapnia. That's what you're expecting, right? Can you have a mixture because this might be chronic? Of course, okay? The same as the respiratory, the same as the renal failure that you have acute and chronic, you can have an acute and chronic on respiratory acidosis, okay? So, patient had a CVA in the past, even more, COPD, CO2 retainer, obstructive sleep apnea, CO2 retainer, patients with past medical history of CVA, I don't know their GCS score so far, CO2 retainers, right? Patient comes with left pleural effusion, hypotension, and altered mental status. Okay? We're going to talk about, I'm not going to talk about right now about the settings and the BiPAP. We're going to talk about that in a minute. Okay? When we finish this PowerPoint. Let's analyze the ABG. What do you have here? 734. Remember 735 to 745, right? So this is low, right? And it's acid. Yes? And then you have 65. When you see the ABGs like that, I don't need to tell you what it is. The normal formula is pH first, PCO2 after, PaO2 next, bicarb, and base excess. Okay? So this is CO2, 65. So I'm not going to give you those in the test because you're expected to know that the second number is CO2, right? So 65, 35 to 45. Remember, CO2 is a value of acidity, right? The more CO2, the more acidity. The less CO2, the less acidity, right? So that is acid. So what matches so far with your pH? Acid, acid, since CO2 is a factor of respiration, I have respiratory acidosis, right? Bicarb is 35. Let me give you a clue here. Normally it's 22 to 26. Whenever you receive a patient in respiratory acidosis that already bicarb or the kidney has compensated, that's chronic. I don't even need to do the calculation, even though you will go through it.
It takes a long time for the buffering to go.
Exactly, because remember, Paco, if you have a metabolic acidosis, the lungs will compensate, and the lungs compensate in minutes. In minutes. On the contrary, and unfortunately, we have to help the respiratory system when it's in failure, because the kidneys takes days to months to compensate. The patient already comes into you in the ER, first day with a 35, more than 26, that's chronic. I'm not saying that I'm not going to treat the patient, but you might even see this ABG in a patient that is reading the newspaper. Normal. Now, my question to you, are you going to incubate the patient?
If it's less than 60, yes.
What did I say before I start the class?
Yes.
Are you going to intubate the patient if the patient meets the criteria of respiratory failure, CO2 of more than 50, and PaO2 of less than 60. This one is not as hypoxemic by formula, but this patient is in hypercapnic respiratory failure. That in clinical practice, if I see you like this, I'm not going to do anything. The least I can do is, how can you blow out CO2? Allowing the patient to hyperventilate, right? But I'm not going to tell you, okay, now breathe, 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 breathe. I can't. You have to stay at the bedside, right? With the patient 24 hours. So you're going to put a patient BiPAP by level ventilation, and you are going to increase the respiratory rate so the patient can hyperventilate, and then you can monitor after. Do you understand? That's what we do in clinical practice, but you're not going to answer that on an exam. Okay? The only thing that you do with the incentive spirometer is to expand the alveoli to avoid attacks, but that's it. So if you can see here, this patient was placed on BiPAP, and what happened?
Got worse.
It really depends on the settings, right? And I will explain to that in a second when we go to that mechanical ventilation session. You see that it's actually worse? And I will tell you even more why it was worse. I don't know the parameters, the settings that were placed on the BiPAP, but I can tell you that if you know the patient from before, if you know this patient has chronic respiratory acidosis, never start with a high level of oxygenation. In clinical practice, never start with a high level of oxygenation because you're actually blunting the respiratory drive of that patient. And that's the reason why it was increased. So 40 might be too much for that. Okay? Even though you're going to hear me saying otherwise after we finish this PowerPoint. Because a test guideline is one thing, and clinical practice is another thing. So I'm not going to confuse you. You're going to answer based on what I'm saying. This is for the test, you do this, but what will you really do in clinical practice? Even though we start all the BiPAP settings, all the ventilator settings, the first time at 100%, it will be very stupid to start this patient at 100% because you would see that the patient will get worse. Exactly. Okay? You're going to understand this later when I talk about BiPAP and mechanical ventilation. Okay? So again, more disease process that can give you hypercapnic respiratory failure. Another patient, again, I'm not going to concentrate on the settings yet. You have a patient with multiple rib fractures. Why would a patient retain CO2? They can't expand properly. And a pneumothorax. Okay? They place a chest tube. Patient had a fracture. And the reason why the patient had a hemopneumothorax, most likely due to coumadin, even though the INR was therapeutic. The patient comes in with respiratory distress at 30, shallow breathing. Okay, patient was breathing deeply. Patient was placed on BiPAP with those settings. With that history. Patient was at 80% on BiPAP, and let's look at the ABG. 745. Is it acid or alkaline?
It's normal, but it's high.
And I will teach you next semester that you can have a normal ABG and still have an underlying disease process. You say it's normal, right? Yeah. But there's always a mean in a number, right? And since 735 to 745 is a normal range, 7.4 is actually the normal range. So if it goes less than 7.4, you have a primary acid problem. And if it's more than 7.4, you have a primary alkaline process. So, 48. Again, is it normal? 35 to 45. 66, hypoxemic, 32, bicarb, 22 to 26. That's not calling, right? Yes or no?
Yeah.
What matches with my pH? Metabolic alkalosis. I can tell you this patient actually, something else is going on. Because you would see next semester as well that the most common disease process that can give you metabolic alkalosis is dehydration, which it could be from bleeding into the thorax, hypovolemia, right? Or there's a major GI process that you're thirst facing. When you have metabolic alkalosis, think about GI problems, okay? So maybe I have another process, or it's just the patient is anemic and hypovolemic because your patient is bleeding. You see that actually sometimes the history doesn't match your ABG, okay? And if it's really due to hypovolemia and the patient is in hyperchloremic, metabolic alkalotic, due to bleeding, you have to drain the chest tube and transfuse the patient. And that will be corrected. But you will learn all that next semester. Okay? Does this patient meet the criteria for respiratory failure? Yes. Is the CO2 more than 50? No. Is the...
Yeah, it's good.
Okay, wait. Respiratory failure is the PaO2 of less than 60, is it?
No.
PaCO2 more than 50, is it?
No.
No, the patient is not in respiratory failure. You have to intubate the patient? No. Just drain the chest tube, give them blood or fluids. Do a CT abdomen because maybe the patient is bleeding in the abdomen too and you don't know. Okay? You're going to learn even more next semester because it's the real stuff acute care. Okay? Really, I see you. This is baby stuff. Now, hypoxemic respiratory failure. This is basically, listen to me, hypoxemic respiratory failure. This is basically mixed in this slide. But I want you to concentrate if ventilation affected your exhale of CO2, and we were talking about opioid overdose, any disease process brain-wise that can affect your GCS, neuromuscular disorders, obesity, etc. What can affect your oxygen? First of all, again, we have been called because the patients are in rapid breathing, okay, and having low oxygenation, and the patients have nothing in the lung. And it's just that the CBC hasn't come up yet, right? But if you look at the history, if you listen to the history, most likely is because the patient is anemic. And exactly like that, chest x-ray normal, ABG hypoxemic, and when the hemoglobin comes out, 5, 6, 4. Once you give transfusion to the patient, that is corrected. What else can affect your oxygenation? You're breathing at a range that is not normal. Normally you breathe at 21% atmospheric air, right? But what about if you go down to Colorado? Yeah. Like my husband and my son fainted in the highest peak.
For real?
Yes, for real. So high altitudes can do that, right?
So why?
The oxygen is thinner up there.
Because you are at a higher level of oxygen.
So
The oxygenation drops, the level drops. Now, but in addition to that, guys, now think about, again, the lung. Even though the lung diseases affect ventilation, lung diseases can also affect oxygenation. If you have asthma, can you have hypoxemia?
Yeah.
If you have pneumonia, can you have hypoxemia? Yes. So all diseases, except the one that can produce hypoventilation, can also produce hypoxemia. Right? That low VQ chanting. Or what about pulmonary embolism as well? Okay? So from chanting to dead space to high altitude to any respiratory failure that you can imagine lung-wise. Okay? So as I told you, if you have now drowning, pneumonias, pulmonary edema, COPD, and basically I am listing anything that can happen to the lung, except when the patients hypoventilate, those diseases can also produce hypoxemia. From the chanting to the dead space. Now let me ask you a question. Of course it's based on the history, but what will you rule out first if a patient comes to the ER with hypoxemia?
PE.
Would pneumonia kill you? Maybe eventually, right? Would interstitial edema from CHF will kill you?
No.
Maybe eventually, but not today. Not right now. So you must rule out PE if you have a high level of suspiciousness based on the history, right? So,
So PE is hyperventilation? No.
hypoxemic.
It's
Hypoxemic. Okay? Hypoxemic due to dead space, as I explained. Okay? So let's talk about the heart. Can heart diseases give you hypoxemia?
Yeah.
Absolutely. From left ventricular failure to any valvulopathies, to any right ventricular failure, from pulmonary hypertension of any cause, right? But don't forget your hemoglobin. And I've seen that a lot. Keeps falling. Now let's talk about, I know what I have to test you, okay? I know your level. And you need to understand where that thing came from. There is something in pulmonary physiology as well that is called AA gradient. Okay? That means arterial alveolar gradient. Remember, why is arterial alveolar gradient? Where is gas exchange being produced? At the interchange, right? Interface of the alveolar capillary membrane. So that's the reason why you need to know what a normal person at a 21% FiO2, which is atmospheric air, should breathe. Just listen to me. If the pressure of the arterial oxygenation is equal to the FiO2 minus 500, where this 500 came from?
How about you?
This 500 came from another ratio, which is, again, the pressure of the alveolar oxygenation divided by the FiO2, which is the 21%. So that means that a person with a 60 kilogram normal average person, okay, male or female, at a 21% ratio of FiO2 should have an oxygenation of, or PA ratio of 500. Listen. And if it's less than that, depending on the ratio, because every year you become older, you drop your PaO2 and FiO2 ratio by 1%. Okay? So, if it's less than 500, depending on the age of the patient, if at 20 years of age you should be 500, discount 1% per age you become older. So that's the reason why we drop or we jump, just listen, to 300. If you have less than 300, your alveolar capillary membrane is compromised and you are in the classification of adult respiratory distress syndrome.
So this would be like an older person perhaps that have like stiff alveoli?
Yes.
Like,
No. This is a disease. Now, if you are between 500 to 300, you're still normal, but I have to consider your age, which we calculate, but that's too much for you.
but if you're less than 300, then you would be
If you're less than 300, for sure, you have a disease
like
process.
pulmonary fibrosis or anything like that.
Right.
So you
But
said-
also, that could include an overtransfusion, which is called TRALI. That could also include adult respiratory syndrome, which is ARDS. Okay? So, you would see in the slide that if you have 300 to 200, you have mild ARDS. If you have 200 to 100, you have moderate ARDS, and if you have less than 100, you have severe ARDS, and that is only to predict mortality. Okay?
Is that a good
I'm
one?
not gonna test you on that part yet, but I want you to listen. Okay?
So you said less than 300 will be alveolar capillary, what?
Syndrome.
Syndrome.
Adult respiratory distress syndrome. ARDS. Have you heard, tell me if you have or not, have you ever heard in the ICU, anybody saying it has a high AA gradient? Okay? How do they know that? Listen, how do they know that? AA gradient is PaO2 equal to a FiO2 minus 500, right? So if you are expected to breathe at 21% minus 500, how much is that? Now you have to minus the amount of PaO2 that you let on the APG.
You know, I still don't understand where you got the 500 from.
It's just a
Just a number,
ratio.
500 is a number.
It's a ratio.
500 is just a
that-
ratio that you should breathe at a 21% atmospheric air based on your age. That's it.
It changes it.
That's it. And you would ask me the same questions when I talk about mechanical ventilation. Where did you get that number from? And I will explain you. That's no more than a ratio based on pulmonary physiology. Okay? It's a fixed number. It's a fixed number.
And this PaO2 is what?
The alveolar, I'm sorry, the arterial, okay? So if you get 479 and you divide, imagine that the PaO2 that you get on the APG is, I don't know, 92. You minus that, 479 minus 92, and that will give you how much?
381.
But 92 will be the
So,
PaO2.
so if you know that the 500 is the FiO2, PaO2 ratio of a normal person. Now you have a 381, is the well, 387, okay. Isn't it greater than 300?
Yeah.
Do you have ARDS?
No.
Oh.
Less than 300.
And that 92 is the what? That 92.
Whatever PaO2 you get on the ABG. Mhm.
Makes sense. So that is called a trigger blood pressure.
I think I'm teaching you more than expected as a result.
No, it's okay.
It's okay.
I feel like I like it because I feel like we should have a semester only in pulmonary.
Now, that is in centimeters of water. Listen to me. That is in centimeters of water. There's another formula. That I'm not going to go through the formula because otherwise it will be crazy. That the result has to give you in a normal person 5 to 10 millimeters of mercury. Okay? So if I tell you, listen, if I tell you that a normal, AA gradient as well. If I tell you that a normal AA gradient in millimeters of mercury should be 5 to 10, and if you receive a value of 30, what could be affecting that? Okay? Diseases that can affect AA gradient most of the time are the diseases that affect VQ mismatch. So if you have a patient with trauma, that's why we use it a lot, but we use it across the ICU. We use it all the time in Kendall. I don't know, you haven't even heard of it. AA gradients are increased, for example, if you have a patient with trauma that has a hemothorax, if you have a patient with rib fractures, the AA gradient will be affected because the ventilation portion is affected, right? So you have to, unfortunately, even if the ABG is completely normal, if your AA gradient remains high, okay, you have to work more on the underlying disease process, otherwise extubation will fail. This is no more, guys, let me tell you in general, to know if the patient is oxygenating at the level it should be. That's it. Okay? That even if you get 82% on the ABG, on the PaO2, it is safe to extubate the patient just because the ABG is normal. Have you seen patients that have a normal ABG and they're still thinking about extubating the patient? That's because the AA gradient is increased. There's another process underneath that will make the patient fail the extubation. Okay? All right? Now, again, what is adult or acute respiratory distress syndrome? Remember that in pathophysiology, this is no more than a major inflammatory response, right? That all these interleukins come out, prostaglandin, prostacyclin, tumor necrosis factor, blah, 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 and produces interstitial edema, bilateral, symmetrical, that has nothing to do with cardiogenic causes. This is a major inflammatory insult. What diseases can give you acute or adult respiratory distress syndrome? And I keep saying adult because this disease is also present in neonates.
Yeah.
When they do have preterm labor and the lung is not preparing yet because there's lack of surfactant. Because in essence, what happens in adult respiratory distress syndrome is that the major inflammatory response will deplete the surfactant released by alveolar type 2. And there's a major alveolar collapse. Okay? So, diseases that can produce this, think about any inflammatory process. From local pulmonary contusion after trauma to even a pneumonia that can produce a major inflammatory response, drowning. But if you come out of the lung, Pancreatitis is the leading #1 GI disorder that can produce ARDS. And how do I know that the patient is in ARDS? First of all, the definition is that the AA gradient, the PaO2 or FiO2 ratio is less than 300. And second of all, this is a refractory hypoxemic respiratory failure that you keep going up 50, 80, 100%, you go up on the peak, you reverse ventilation, and the patient remains hypoxemic. But in addition to that, there's a diffuse whiteout, bilateral asymmetric pulmonary edema that when you do an echocardiogram is normal. Or the same baseline the patient had before. That can the patient eventually, due to the progression of this disease, can compromise EF? Yes, but it wasn't initial insult. Okay? And it actually evolves really rapidly. Sometimes if you have an aspiration pneumonia, which is an insult, you see a normal, clear x-ray. I have a patient right now that I saw on Sunday. Patient was a stroke. Patient was recovering really well. And suddenly the patient started having coffee ground emesis. And I knew as a fact that that patient would have aspirated. Even though the x-ray that night was normal, the next day was normal, clinically the patient shows signs and symptoms of aspiration pneumonia. That patient in less than 48 hours could, because it's not frequent, but it happens, could evolve to ARDS. Okay? It's not the same having aspiration pneumonia with multifocal infiltrate or right basal or left basal infiltrates that having from aspiration pneumonia diffuse bilateral symmetric pulmonary edema that the initial insult was the aspiration pneumonia because that patient never came in with CHF, right? And the vomiting produced an inflammatory response enough to put the patient in hypoxemia. And if I put the patient now on ventimask and I see myself going into non-rebreather and I see myself going into BiPAP and then intubating the patient and going into up to 100%, that meets the criteria for ARDS. Plus, if you calculate the AA gradient, the PaO2 FiO2 ratio will be less than 300. Okay? So this is the pathophysiology that I told you. You remember, when you have a major inflammatory response, you have leukotrienes, tumor necrosis factor, all those interleukins being released, right? And what happens is that not only you're going to have vasodilation in the lung, producing pulmonary hypertension, and due to an acute insult, and producing leakage of fluid and pulmonary edema, but in addition to that, alveoli type 2 will be affected, and surfactant will not be released, and these patients will have a major atelectatic event. Doesn't mean that the lung collapses up to the point of atelectasis and pneumothorax, but it's really, really hard to ventilate those patients, to open those alveoli. Therefore, that's the reason why there's a questionable, including hydrocortisone or solometrol on these patients due to reduced inflammatory response, and actually give them fluids instead of giving diuretics. And I see a lot of practitioners that they don't know before the patient reaches the ICU that is diuretic, diuretic, diuretic. This is a non-cardiogenic pulmonary edema. How you treat infections or inflammations are with anti-inflammatories and fluids. have all this that that's great. As you could see, yes.
What if it's pleural effusion on top of the edema, and that's why they're doing this?
Okay.
Because we see that a lot.
Okay, yes. But again, the pleural effusion is expected. If you give diuretics and they're good result. No, they don't. They don't. They don't. Sometimes you make the case worse. What you can do, which is not indicated because this patient would have a high peak, is do thoracentesis. But just wait for the process to resolve and they will get better. I have seen them too, giving Lasix. Doesn't work. Okay? As you can see, this is a diffuse, look at, this is a normal color of a lung. And look at this. Do you see it or not? Okay? This is completely different. This is just a bulla. You know, most likely a patient that had ARDS on an emphysematous patient. Okay? Now, if you remember patho, ARDS had 3 phases. The exudative phase is where all these leukotrienes are released and there is exudate, meaning that leakage of fluid to the outside, right? With high levels of protein. Proliferative phase continues, and then you have the alveoli step 2 being damaged, surfactant being damaged, alveolar collapse. Up to these patients can survive, because the mortality is really high. These patients can survive and can't end up with pulmonary fibrosis. Look at all the diseases that can produce ARDS. From any infectious cause, aspiration pneumonias, contusions, pulmonary embolism, near drowning, smoke, inhalation injury. You are in a fire, you can get ARDS. Okay? Transplants when the patients are immunocompromised. Okay? Sepsis, burns, trauma, as I said. TRALI, which is transfusion reaction due to, I'm talking about massive amount of transfusions in a patient that, for example, has a GI bleed. Okay? Patient with cirrhosis, for example, that comes and bleeding, and then transfusing, and then at the end of the shift, they make the patient CMO, that way. Okay? How much of an insult to the body can burn produce? Now, she might be thinking about, wait, this is in the skin, it's not even in the lung. It doesn't matter. Remember, you can have osteomyelitis in your toe, and you can get a severe inflammatory response to the point that you can have leakage of fluid anywhere in your body. Anywhere.
No,
Okay?
You can also inhale all that CO2 from the burn.
So we see it a lot on patients that, for example, are clean, they clean the pool. We have had patients like that. Cleaning the pools and mixing acid with the chlorine. They inhale that, they go into the ARDS. Okay? So any toxic fume. Cocaines, most likely what they do have is cavitary lesions and fat embolies. But they can also get, due to severe chronic inhalation, a major inflammatory response. But again, acute pancreatitis is the leading #1. That's the reason why they have to be highly observed in the ICU when they have a high Ramsay criteria. Now, in addition to that, we have a law in pulmonary that you should always try to give the patient a low tidal volume and a higher peak. Why? Well, first of all, in the past, before ARDS was discovered, we did discover that there's 2 major traumas. One, volo trauma, that the alveoli could collapse, right? Because you expand like a balloon and they lose their flexibility. If you inflate and inflate and inflate and inflate something over time, every single day, the elasticity of that, whatever it was, right, it decreases, right? So at a certain point, the elasticity of the alveoli will decrease and the alveoli will collapse, right? That is called volotrauma. So we started decreasing the tidal volume first, then increasing the pressure to be able to open the alveoli, which is called P, positive expiratory end pressure, right? And we also see that by increasing the pressure, you can also provoke trauma to the alveoli, which is called barotrauma. Baro by pressure, barometric, right? Barotrauma. But anyways, we made the conclusion in ARDS, and we have applied it all across the diseases, that you have to always give a lower tidal volume and increase in P. And mostly in this disease process, because what did I just explain? That loss of surfactant will produce a massive alveolar collapse. So to be able to maintain those alveoli open, you need to work more on increasing the P. And when you're weaning these patients off the ventilator, you have to wean them off first in oxygen, FiO2, leave the PEEP alone, don't touch it. I'll explain this again. And up till you get to 50% if you were in 100. Once you're in 50%, you start decreasing your PEEP, and then you wean the patient to any other before extubation. Okay? I'm going to make you calculate tidal volume and all that in a second. All right? So, if I tell you that a normal person, you and me, even with any disease process except ARDS, should have a tidal volume of 6 to 8 mL per kilogram, the ARDS patient should start off lower, 4 to 6 mL per kilogram. Just know that so far.
6 to 8 with what?
You,
No.
me, normal people, without ARDS. With any disease process, but not ARDS. Do you understand? Okay? So, what is the best treatment for ARDS? That's a question. Treat the underlying cause. Of course, this patient is going to be on the ventilator. And it's going to be on the ventilator for a little while until you treat the underlying condition, whatever it was. If it's trauma, if it's burn, we're going to talk about all that in 669. Now, if the disease process was an infectious process, you treat according to the disease process, right? If it's pneumonia and the patient is in the RDS, in the ICU, on a ventilator, what will you give? What type of antibiotic? What is broad? If you choose, remember, if you choose Sozin, that you only cover gram-positive with Pseudomonas, right? You need to add Vanco. If you choose Cefepime, with Vanco, right? Always cover everything first, if this patient is highly ill, and then you could escalate based on microbiology, okay? Based on cultures. You have to start nutrition support as soon as possible, okay? This patient, for example, is not going to any type of surgical procedure. In the next 24 hours, you start nutrition. Highly, highly recommended because hypovolemia could deteriorate this process even more. Okay? And we're going to talk about the ventilator in a second. Any questions so far? No? So the ARDS.net recommends on their guideline these principles, okay? And the first principle is that try to stay, even though they recommend to go higher on PEEP than on tidal volume because of the alveolar collapse, loss of surfactant. They say that try to use the lowest PEEP possible. Possible, I'm not saying that if you have to stay at 20, you have to stay at 20.
Wow.
Right? Have you seen those?
Yeah.
Yes.
15,
20.
I said 15.
Okay? Yes. In trauma patients, I have seen 26. But wouldn't have that at risk of more pneumothorax
Yeah.
than 10. Well, that's their recommendation, but I've seen more. Okay? That the tidal volume, remember, their tidal volume should be 4 to 6 mLs per kilo. The highest that you can use for them is 6. That's the highest. If you're smart, what will you do for everyone? Start 6. Hello? If a normal patient is 6 to 8, and a RDS is 4 to 6, what will you choose?
Yeah, but the thing is that 4 is the safest.
But not on you. No, you have pneumonia,
So you
Right?
put 4, right?
you will start at 6 for everybody.
But you have to choose.
All right? Now, what is plateau pressure? When you are on a ventilator, guys, this is physiology and I know it's boring, but I have to tell you because otherwise I'm just reading a PowerPoint, okay? If this is the ventilator, okay, on a graph,
For sure.
normally when we breathe, if you remember your volumes and your capacities, when we breathe, normally again it's tidal volume, right? If I tell you now, take a deep breath and hold it, what is that? Maximum or forced inspiratory capacity, right? And then take it out, exhale as fast as you can, so forced expiratory volume, right? But can you exhale everything you can inhale?
No.
Impossible, because otherwise, what would happen? The alveoli will collapse. Therefore, we all, unless you're an obstructive disease, we all should have a remaining 5 millimeters of mercury in our alveoli at the end of expiration. And that's the reason why we choose 5 as a peak for everyone to start. So I will never ever go to 0 in a graph, okay? So this is a patient, listen, this is a patient that takes a deep breath and then expires, right? No death. Exhale, exhale, right? And another one, inhale and exhale. What about if I now, on the ventilator, I would hold inspiration? If I hold the inspiration, the graph is going to do this. Until I release it, and the patient would exhale. This is called plateau pressure, okay? And the plateau pressure should be less than 30 centimeters of water. The machine will tell you, the computer, the ventilator will tell you pressure, okay? Because if I have a higher plateau pressure, that means that I have a lot of end-tidal and my patient could have alveolar collapse.
Is millimeter of mercury or water?
It's interchangeable depending on the mechanism they use, the ventilator they use, same thing, okay? So, huh? Okay? So, in addition to that, ARDS.net recommends, listen to this, an inspiration expiratory ratio of a 1:1. How do we normally breathe? Is our inspiration equal to expiration?
No.
Is our expiration longer than inspiration?
It's short.
Yes.
Longer.
Yes.
Inspiration is longer than
Inspiration is longer.
expiration.
Two, ratio, I believe is too
long. So, normally, we breathe at a ratio of 1:2. In patients with ARDS, when you have already reached 100% and 10 of peak, I understand that we go up on the peak first, but their recommendation is that you start inverting the ratio. Okay? You start with a 1:1 ratio up to the point that you can increase inspiration and shorten expiration to allow what's called permissive hypercapnia. Because they rather compromise ventilation, patient retaining CO2, than oxygenation. You oxygenate more, that's what they care, right? Rather than, you know that I can't, you can tell right now that I'm asthmatic. So, normally your inspiration is short and your expiration is twice as long. If you shorten expiration, you improve oxygenation at the expense of CO2 accumulation. And that's okay. So never ever expect to put CO2 on a normal value on ARDS patients. That is contraindicated. Okay? That's what they mean. And as I told you, when you start winning the patient, win the FiO2 first before you win the peak. Okay? Always do an echo. Why? Do an echo at the initial stage just to make sure that this is not related to heart. And do an echo if the patient doesn't improve later on, 5 days, 7 days. Why? Because can this patient deteriorate EF? Okay? Prone position, have you seen them on the rotoprone bed? It's just for lung expansion. Okay? And these patients can even end up in ECMO. And as I told you, steroids is a questionable, it's still in debate. For years and years and years, we give a stress dose of hydrocortisone anyways. Okay? But it's questionable because sometimes it doesn't even work in patients. But isn't the actual etiology an inflammatory response? So at least cover the patient.
Perfect ECMO. I heard about that, but I never seen it.
It's an extracorporeal oxygenation of the membrane. Not only for ARDS. It's like a dialysis,
But in the long.
but for actual oxygenation. Any questions so far? No? We're gonna go to the nitty-gritty.
This was the
No. Take a break.